Welcome to the PURA Syndrome podcast. If you've ever, relied on a medical diagnosis to give you a clear black and white answer, you know the absolute comfort of certainty.
Oh, absolutely. I mean, you break your arm, the x-ray shows a jagged white line, and the doctor just points to it and says, there's the problem.
Right. Here's the problem. Here's the cast. It's visual, it's localized, and it's fixable in this very linear way.
But when you step into the world of complex neurodevelopmental genetics, that x-ray machine is basically useless.
Totally useless. We're pulling you into a space today where the diagnostic landscape is, well, it's incredibly murky.
Yeah, murky is the perfect word for it.
And I really want to speak directly to you right now, the parent or carer listening to this, who's managing the life of a child with PURA syndrome. We know you're out there, quietly coordinating this breathtaking amount of medical and sensory complexity.
Every single hour of the day, you're managing feeding tubes, tracking seizure activity, and navigating a medical system that often knows less about your child's condition than you do.
Which is just a staggering reality for so many rare diseases. For our deep dive today, our mission is to really unpack this condition, with a massive focus on the vision and hearing connection.
Right, because the sensory stuff is so often overshadowed by the acute medical crises, but it's vital.
Exactly. I was up late last night poring over our sources, the clinical characteristics from the Human Disease Genes database, these massive genomic analyses, insights from the PURA Syndrome Foundation, and some recent clinical case reports.
There is a lot of dense data in there.
There is. But the sheer paradox of this condition just stopped me in my tracks. Okay, let's unpack this. We're talking about an infinitesimally small spelling error in the DNA, right?
Right, a microscopic typo.
But it causes this profound whole-body systemic storm. It transforms the simplest sensory inputs, like your child seeing a colorful toy or, hearing a door close, into these overwhelming neurological events.
It really is the ultimate biological paradox. I mean, to understand why a door slamming can trigger a neurological crisis, we have to start at the absolute foundation. We have to look at the geography of the genome itself.
Okay, let's go down to that chromosomal level. The Cleveland Clinic overview notes that the root cause stems from heterozygous pathogenic variants in the PURA gene. Break down the mechanics of that for us.
So heterozygous basically means you have one normal copy of the gene from one parent and one mutated copy from the other.
Okay.
That's the baseline. You inherit two copies of almost every gene.
Mm-hmm.
But in PURA syndrome, having just one broken copy is enough to cause the entire disorder.
Right, what they call haploinsufficiency.
Exactly. If you think of your cells as a manufacturing plant, the body simply cannot make enough of the required product with only one working assembly line. The single working copy is trying to do the job of two, and it falls critically short.
And that assembly line is located at a very specific address, right? 5q31.3 on chromosome 5. But what really struck me in the genomic literature is how incredibly unique this specific gene is. It's classified as a single exon gene.
Yeah, that is the crucial architectural detail that makes this gene so incredibly vulnerable.
How so?
Well, to conceptualize this, think of a typical gene like a rough draft of a novel. Most genes are broken up into chapters containing the actual story. Those are the exons.
Right, the useful information.
Exactly. But between those chapters are dozens of blank pages, or pages filled with just random scribbles, which we call introns.
And the cellular machinery has to edit that rough draft, doesn't it? Like, it reads the chapters, physically cuts out all the useless blank pages, and splices the text together.
That's exactly how it normally works. But PURA is a single exon gene. There are no blank pages.
Wow, so no introns at all.
None. There is no splicing process. It's just one continuous, uninterrupted block of dense genetic code.
Which means there is absolutely zero margin for error. Like, if there is a mutation, the body can't just edit it out or splice around it.
Exactly. The error is transcribed directly and permanently. And this specific, highly vulnerable block of code provides the exclusive instructions for manufacturing a protein called pure alpha.
And pure alpha is kind of a marvel of evolutionary biology, isn't it? The sources say it's highly conserved.
It is. Highly conserved means if you look at the pure alpha protein in a human and then look at it in a mouse, or even in much simpler organisms, it's almost identical.
Oh, wow. So evolution just decided, don't touch this.
Basically, yeah. Evolution figured out millions of years ago that this specific protein is so fundamentally essential for life that it locked the design in place.
The literature says it's essential for cellular homeostasis across the blood, the muscles, the heart. But its primary job, the really complex stuff, happens in the brain, right?
Yes. In the developing brain, PURA alpha acts as this master regulator. It guides the proliferation of neural cells in the embryo.
And it helps mature the dendrites, too, those branch-like structures connecting the neurons.
Exactly. And crucially, for our discussion later, it's a primary driver in the formation of myelin. That's the insulation around our nerves.
I really want to dig into the physical structure of this protein, because the biochemical depth in these sources really explains the why behind the symptoms. PURA alpha is made up of 322 amino acids, right?
That's right. But inside that chain, there are three highly specific regions called PURA repeats. PURA repeat 1, 2, and 3.
Okay, those repeats are the functional heart of the protein. How should we visualize those?
The best way to visualize these three regions is to picture them as molecular grappling hooks.
Grappling hooks.
Yeah. Their entire physical purpose is to hunt for and bind to very specific sequences of raw genetic material DNA and RNA, specifically purine-rich sequences.
Okay, so it's a protein that acts like a claw, grabbing onto the genetic blueprints. What is it actually doing with those blueprints once it hooks on?
Well, outside the nucleus, its job is vital for memory and learning. It serves as the primary transport vehicle for messenger RNA or mRNA. Let's imagine the developing brain as a sprawling, massive construction site.
Oh, I love this analogy. Let's build it out.
Okay, so the PURA alpha protein is your master Foreman. The Foreman's job is to carry the blueprints, the mRNA from the architect's office in the center of the cell, load them into a transport truck, and drive them out to the furthest construction zones.
And those outer construction zones are the dendrites.
Exactly. Those long, winding roads down the neuron lead to the dendrites.
And the builders of the dendrites need those blueprints to know how to lay the bricks.
And the bricks are new synapses. The dendrites rely on a process called local protein synthesis.
Meaning they don't have time to wait for the main office to build it and ship it.
Right. They need the raw instructions delivered right there, on site, so they can build new memory connections the exact millisecond. The brain learns something new.
I was looking at the global patient registry data, and the most common mutation they see worldwide is called the P.Phe233del variant. Let's map that onto our construction site analogy.
Okay, let's do it.
The literature says this specific mutation deletes a single amino acid phenylalanine at the 233rd position, just one piece missing out of 323.2.
But molecular modeling reveals exactly where that one missing piece is. It happens right smack in the middle of PURA repeat 3.
Wow. So it hits the grappling hook directly.
It shatters the beta sheet structure of that specific grappling hook, yeah.
So our master Foreman's hand is broken.
Yes. The Foreman can no longer hold onto the blueprints. The protein structurally distorts, meaning it can't bind to the mRNA.
So the transport trucks just never leave the architect's office.
They never leave. The blueprints never reach the dendrites. Local protein synthesis utterly fails. And because of that, normal postnatal brain development essentially grinds to a halt.
The builders are just standing around in the dark. It is deeply humbling that such a microscopic, localized distortion dictates the entire trajectory of a human life. Now, something that brings up a lot of complicated emotions for parents navigating this is the origin of the mutation. The reports almost always classify these as de novo.
De novo translates to anew. In the vast, vast majority of PURA cases, neither parent carries this mutation in their own DNA.
Right. The parents are genetically typical.
Yeah. The spelling error occurs completely spontaneously, usually during the formation of the specific egg or sperm, or during the very first microscopic cell divisions of the embryo itself.
Which means, and I want to say this incredibly clearly to you, the listener, there's absolutely nothing you did to cause this.
Nothing at all.
It wasn't the cup of coffee you had in the first trimester. It wasn't stress. It wasn't your environment. It is a completely random, spontaneous biological event, a roll of the genetic dice.
That is vital to internalize. And because it is spontaneous, genetic counselors typically quote the chances of the same parents having a second child with PURA syndrome as less than 1%.
Before we move out of the microscopic world and into what the parents actually experience in the hospital, I have to bring up a speculative point from the genomic studies that blew my mind.
Oh, about the repeat extensions?
Yes.
Right.
Because while PURA syndrome is ultra rare, I think maybe 700 or 800 confirmed cases globally right now, studying it might actually be the key to unlocking some of the most devastating, widespread neurological diseases in the world.
It is a phenomenal area of active research. Remember those molecular grappling hooks we discussed?
Yeah.
It turns out that pure alpha has a very strong affinity for binding to expanded hexanucleotide repeats in a gene called C9orf72.
And for anyone who follows neurodegenerative research, those specific genetic stutters are the primary known genetic link to ALS Lou Gehrig's disease and frontotemporal dementia.
It's incredible. Furthermore, scientists have mapped pure alpha binding directly to the CGG repeats in the FMR1 gene.
Wait, isn't that the exact gene responsible for Fragile X syndrome?
It is the most common inherited cause of autism.
So studying the master Foreman, observing what happens when the transport trucks fail in these children, could fundamentally map the mechanisms behind major repeat expansion disorders.
Yes. These kids aren't just managing a rare disease, they are unknowingly pioneering a frontier of neurology that could save millions of adults from ALS.
That is a profound legacy built right into their cellular biology. But, while understanding the mRNA transport mechanism is crucial for the researchers in the lab, that is not what the parents see.
No, not at all.
What the parents see happens in the terrifying clinical glare of the delivery room, or the neonatal intensive care unit. Let's bring this genetic blueprint into the physical world. How does a shattered grappling hook present in the first hours of life?
For almost every family, the PURA journey begins with a severe, acute medical crisis right at birth. The neonatologists immediately observe a classic triad of symptoms.
Okay, what's the first one?
The first is profound hypotonia.
Low muscle tone. The medical notes often use the clinical term Floppy Baby Syndrome, and the sources say this affects over 95% of infants with the mutation.
Yeah, it's nearly universal.
But the literature makes a very sharp distinction about the nature of this hypotonia that I want to unpack. Because it's not like other muscle diseases, is it?
No, the distinction is critical for diagnosis. Hypotonia can originate from two places, the peripheral nervous system or the central nervous system.
Okay, so peripheral would be like spinal muscular atrophy.
Exactly. In conditions like SMA, the problem is peripheral. The peripheral nerves connecting to the muscles are actively dying, so the muscles waste away.
But in PRA syndrome, the hypotonia is entirely central in origin, meaning the muscles themselves in a newborn with PURA are perfectly healthy.
The muscles are pristine, the physical hardware of the bicep or the hamstring is totally fine, the peripheral nerves are intact.
So the failure is central, it's in the brain.
Right. The cerebral cortex and the basal ganglia simply aren't generating the continuous resting electrical signals required to tell the muscles to maintain a baseline tension.
And neurologists test for this immediately in the NICU, right, using reflexes.
Yes, they perform a deep tendon reflex test, tapping the knee, checking the ankles.
And if it were a peripheral muscle disease, those reflexes would be completely dead.
Exactly. But in a baby with PURA syndrome, those deep tendon reflexes are usually completely intact or even exaggerated and brisk.
So a brisk reflex is a massive diagnostic flare for the neurologist. It proves the peripheral loop is working and points the investigation straight up into the brain.
Spot on. But regardless of the origin being in the brain, the physical effect on the infant is total. A baby with severe central hypotonia can't maintain their posture.
They can't lift their limbs against gravity.
Right. And most dangerously, this profound weakness affects their airway, which leads to the second symptom of the triad, respiratory insufficiency.
Over 50% of these neonates experience recurrent, life-threatening apneas. And the mechanism of this breathing failure is actually twofold, isn't it?
It is. First, you have the mechanical failure, obstructive sleep apnea.
Because the muscles of the throat are so weak.
Yeah, the pharynx, the soft palate, they're profoundly hypotonic. So the actual tissue of the upper airway physically caves in under the negative pressure of inhaling.
It's like trying to forcefully suck air through a wet paper straw. The walls just collapse.
That's a great way to picture it. That is the obstructive component. But the second type is arguably more complex and deeply tied to the PUR-alpha protein, central apnea.
This is where the brainstem itself simply forgets to send the signal to breathe, right?
Exactly. Specifically areas like the pre-Butzinger complex, which generates the rhythmic drive to breathe.
The Foreman dropped the blueprints for the autonomic nervous system.
PUR-alpha is heavily expressed in the embryonic brainstem. Without it, the neural networks that control autonomic functions just don't wire correctly.
So the baby's drive to breathe is erratic, shallow, or temporarily just turns off completely.
Which is terrifying. This is why you see these infants requiring mechanical intubation, CPAP machines, and heavy supplemental oxygen for weeks or months.
Which ties directly into the third part of the neonatal triad: severe dysphagia, or feeding difficulties.
Mm-hmm.
Because if you can't control your airway and you have no muscle tone, taking milk is basically impossible.
Taking milk from a breast or bottle isn't just a reflex. It is one of the most neurologically complex things a human infant does.
It requires the suck-swallow-breathe cycle.
Mm.
I was reading about this. You have to generate suction with hypotonic cheeks,
Yeah.
push the milk back with a weak tongue, trigger the epiglottis to close over the trachea so you don't aspirate, and pause your breathing for exactly a millisecond.
All while your brainstem is already struggling to maintain a basic breathing rhythm. It is a miraculous feat of cranial nerve coordination.
And for an infant with PURA, that coordination is shattered. The risk of silent aspiration is terrifyingly high.
Very high. Silent aspiration is where milk slips past the vocal cords and enters the lungs, causing acute aspiration pneumonia.
Which forces the medical team to bypass the mouth entirely. The data shows over 80% of these babies require an NG tube, a nasogastric tube passed down the nose, just to survive those first weeks.
And for many, the dysphagia is so chronic they require surgery for a gastrostomy tube, a G tube, placed directly into the stomach.
Now wait, I have to push back here for a second, or at least ask you to reconcile something that seems like a massive contradiction in the literature.
Okay, what is it?
You just explained that the genetic deletion is permanent, the brainstem is miswired, the hypotonia is severe. Yet the clinical overviews explicitly state that for many of these children, the ventral apneas and the respiratory crises gradually improve or even resolve after the first year of life.
They do, yes.
But if the gene is broken forever, how does the breathing get better? That sounds like the body is fixing the genetic code, but you just told me it can't.
What's fascinating here is the difference between a genetic repair and physiological compensation. You're right, the body does not fix the genetic code. The PUR alpha protein is still missing. But what we are witnessing is the sheer power of neuroplasticity and physiological maturation.
So the hardware upgrades itself, even if the software is buggy.
Exactly. Over the first 12 to 18 months of life, the infant's brainstem physically grows. The neural networks expand. It's not a perfect network, but sheer physical volume allows it to compensate enough to stabilize the baseline autonomic drive to breathe.
Oh, wow. And what about the obstructive airway collapse?
Concurrently, the physical diameter of the infant's airway grows larger and the cartilage stiffens, which drastically reduces that wet paper straw effect.
So the breathing stabilizes, but the underlying neurological weakness remains.
Yes. The respiratory crises fade, but the profound global hypotonia does not. The low muscle tone becomes the defining, lifelong barrier to their gross motor development.
It's the primary reason milestones like sitting, crawling, or walking are delayed by years, or never achieved at all.
Unfortunately, yes.
So the family survives the terror of the NICU. The apneas begin to space out, the G-tube is managing the calories, and the child grows into toddlerhood. But the relief is usually temporary.
Because the battlefield shifts.
Right. We move away from the lungs and the feeding, and the pathology travels back up into the brain. We enter the era of the neurological storms.
We are moving into the complex landscape of epilepsy and profound sensory processing disorders.
Let's address the epilepsy first, because the statistics are daunting. The registry shows that over 50% of children with PURA will develop epilepsy, typically starting between ages 2 and 5.
And it is rarely a simple, easily managed epilepsy. Because the genetic defect is global, it's present in every single neuron in the brain. We are often dealing with refractory epilepsy.
Refractory meaning it resists standard pharmacological treatment. You can't just find a tiny focal point of misfiring neurons and surgically remove it. The whole network is unstable.
Exactly. The lack of pure alpha disrupts the delicate balance between excitatory neurotransmitters like glutamate and inhibitory transmitters like GABA. The brain is electrically hyperexcitable.
And the seizures often begin subtly, right, like myoclonic jerks.
Yes, which to a parent might just look like a sudden involuntary muscle twitch or the child's head dropping for a split second.
But over time, the electrical storms can organize and generalize. They can progress to generalized tonic-clonic seizures involving full-body convulsions and loss of consciousness.
And in a subset of the most severe cases, the epilepsy evolves into Lennox-Gastaut syndrome,
Which is a devastating, highly aggressive epileptic encephalopathy. It involves multiple different types of seizures every single day and is deeply associated with severe developmental regression.
Managing it requires an exhausting polypharmacy approach, stacking heavy anti-seizure medications, implanting vagus nerve stimulators, or using strict ketogenic diets just to get a baseline level of control.
But here is where we need to sharply pivot to the core mission of today's deep dive.
Because interspersed with these true, measurable electrical seizures, these children are experiencing something else.
Yes, something the sources highlight as deeply distressing yet frequently misunderstood.
The pathological startle response and severe hyperacusis.
Hyperacusis is an extreme, physically painful hypersensitivity to everyday auditory stimuli, and it is the direct trigger for the pathological startle response.
This is where we need the why. Why does the sound of a dog barking next door or a spoon dropping on the kitchen floor send a child with PURA into a massive whole-body neurological event?
This raises an important question, and it comes back to myelination. Earlier, we mentioned that pure alpha is essential for the cells called oligodendrocytes, which wrap our neural axons in myelin.
Right, myelin is the protective, fatty insulation around the nerves.
Yeah.
If the nervous system is the electrical wiring of a house, myelin is the rubber coating around the copper wires.
In PURA syndrome, MRI scans routinely show delayed or severely deficient myelination in the brain's white matter. Now imagine a healthy auditory system.
Okay.
A sound wave hits your ear, travels up the nerve, and enters the brainstem. In a typical brain with healthy myelin, the brain instantly filters that sound. It decides the falling spoon is not a predator, dampens the signal, and your physical reaction is just a tiny, instantaneous flinch.
But for a child with PURA whose white matter is deficient?
Their electrical wires are bare. They are uninsulated.
Oh, wow.
When that same acoustic signal hits their auditory cortex, there is no dampening filter. The electrical signal essentially arcs across the bare wires. It creates a massive, uncontrolled short circuit.
So the brain interprets an everyday sound as a catastrophic threat.
Yes.
Yeah.
Which triggers an exaggerated whole-body startle response. The arms fly out, the eyes widen, the body goes rigid. It looks almost identical to an exaggerated Moro reflex that infants have, but it persists into childhood and is violently intense.
And this creates an absolute diagnostic nightmare for the medical team, doesn't it? And an agonizing reality for the parents.
It does. Differentiating between a true myoclonic epileptic seizure, an electrical storm in the brain, and a non-epileptic hyperacoustic startle response is notoriously difficult. To the naked eye, a massive body jerk looks like a seizure.
But the underlying mechanism is completely different. One is an unprovoked electrical misfire. The other is a physiological short circuit triggered by external sensory input. Why does the medical distinction matter so much?
Because the treatment protocols are entirely opposite. If a neurologist misinterprets a hyperacoustic startle response as worsening epilepsy, their clinical reflex will be to increase the child's anti-seizure medications.
And those medications are heavy central nervous system depressants.
Exactly. You end up unnecessarily sedating the child, suppressing their respiratory drive, and halting whatever cognitive development they were making, just to treat a seizure that was actually just a sensory processing failure.
This is why meticulous, continuous video EEG monitoring is the only way to confirm what is actually happening in the brain.
It's absolutely essential.
This requires an unbelievable level of environmental engineering from you, the parents.
Yeah.
You aren't just raising a child, you are curating their sensory intake.
You're putting felt pads on every cabinet door. You disable the doorbell.
Right. You can't go to a busy restaurant or school assembly or even a loud family Thanksgiving without high-grade noise-canceling headphones. Because a sudden unpredictable noise doesn't just annoy your child, it triggers a physiological crisis that drains their cognitive battery for the rest of the day.
It enforces a state of chronic hypervigilance on the entire family unit. The child is physiologically overwhelmed by a world that is fundamentally too loud.
And while their hearing system is essentially a bare wire letting in a chaotic flood of input, their visual system is struggling with the exact opposite problem.
Right, it's providing scrambled, uncoordinated data to the brain.
Let's look at the other half of this sensory equation. The sources are definitive about this. Early, rigorous intervention by a pediatric ophthalmologist is an absolute non-negotiable requirement for these kids.
The literature details a multifaceted breakdown of visual acuity and ocular motor control. We are looking at high rates of strabismus, which is the physical crossing or drifting of the eyes.
And profound refractive errors too, like severe myopia.
Yes, meaning they are extremely short-sighted. The registry also notes instances of nystagmus, characterized by rapid, involuntary jumping eye movements, and disconjugate eye movements where the brain fails to direct both eyes to move together.
There is also a very specific anatomical issue highlighted in the surgical literature called Brown syndrome. Explain that mechanism for us.
Brown syndrome is slightly different from the general neurological weakness. It is a mechanical restriction in one specific structure, the superior oblique tendon sheath.
Okay, what does that sheath do?
It acts like a pulley to help the eye look downwards and inwards. In Brown syndrome, that sheath is physically tight or restricted, actively preventing the eye from elevating, particularly when looking toward the nose.
But for the other issues, the strabismus, the jumping eyes, is the eyeball itself fundamentally defective? Like, are they blind?
No, the physical anatomy of the eye, the cornea, the lens, the retina, is typically structurally sound. The failure, once again, is neuromuscular.
Because human vision requires an almost incomprehensible level of micromuscular coordination.
Exactly. There are 6 tiny, highly specialized extraocular muscles attached to the outside of each eyeball. And the brain has to constantly send microvoltage signals to those muscles to keep the eyes perfectly aligned, so the visual cortex can fuse the 2 images into a single 3D picture.
Now, overlay the defining feature of PURA syndrome onto those tiny muscles: severe central hypotonia.
The supranuclear control centers in the brain, the areas that calculate exactly how hard to pull each eye muscle, are disorganized. The muscles themselves lack resting tone.
So one muscle pulls slightly too hard, the opposing muscle's too weak, and the eye drifts.
They try to track a moving object, but the muscles fatigue instantly, causing the eyes to jump or lose fixation.
Think about the immense cognitive load of that. Imagine you, as an adult, trying to learn a completely new, complex task. But while you are learning it, you are forced to look through a camera lens that is constantly dropping out of focus, panning left when you want to look right, and periodically splitting your vision into double images.
It would be agonizing.
Your brain would be so exhausted just trying to interpret the visual static that you wouldn't have any processing power left to actually learn the task.
That is exactly the reality for an infant with uncorrected PURA syndrome. And it is why the ophthalmology appointments are not just about cosmetic alignment of the eyes.
Visual health is inextricably biologically linked to cognitive development. How so? Walk us through that developmental cascade.
Well, a typical infant builds the foundational networks of cause and effect, motor planning, and social bonding through vision. They see their mother's face clearly, so they smile.
Or they see a brightly colored block on the floor, which creates the desire to reach out, initiating a complex motor plan.
Exactly. But if they have severe uncorrected myopia, that block doesn't exist to them. It's just a blurry gray shape. And if they have uncorrected strabismus, their brain receives 2 conflicting images.
And the developing brain hates double vision, right?
It despises it. So to adapt, the visual cortex will actually begin to actively suppress or ignore the image coming from the drifting eye.
Meaning, if left uncorrected for too long, the neural pathways to that eye permanently atrophy.
Yes, resulting in irreversible vision loss known as amblyopia or lazy eye.
So when a parent fights to get a specialized retinoscopy for their nonverbal child, or when they agree to put their toddler through eye muscle surgery, they're not just fixing a squint, they are actively rescuing the child's neural pathways.
They are providing the clean, focused sensory input the brain requires to engage with reality. They are jump-starting the child's cognitive engagement.
Which brings us to the ultimate crescendo of this entire sensory discussion. Because when we talk about surgically correcting strabismus and aggressively dampening the acoustic environment, we are ultimately doing it for one singular vital reason.
We are doing it to give the child a voice.
This is where the visual and auditory connections collide with the most profound developmental hurdle in PURA syndrome: communication.
This is perhaps the most emotionally complex data point in the entire natural history of the disease. The clinical consensus is stark. The vast majority of individuals with PURA syndrome are entirely non-speaking.
They will likely never develop the physiological capability to produce fluent, expressive verbal speech, which is a devastating reality for any parent to mourn.
It really is.
But I want to push on this because the sources, specifically the parental reports in the global registry, highlight a massive discrepancy. If they can't speak, how do we know they aren't just profoundly intellectually disabled across the board? How do we know there is an active intelligence trapped in there?
We know through rigorous observation of their receptive language. There's a monumental gulf between what a child with PURA understands receptive language and what they can physically say, which is expressive language.
Right. So the neurological networks that process incoming speech, like Wernicke's area, are often highly functional.
Yes. Parents and therapists universally report that these children follow complex, multi-step commands. They understand humor. They perfectly read the emotional tone of a room.
They possess a rich, complex internal life, and they are overwhelmingly described as highly social and deeply affectionate. The intelligence is there. The comprehension is there.
So why are they locked in? If Wernicke's area understands the joke, why can't Broca's area and the motor cortex tell the mouth to laugh or speak?
Because expressive speech is arguably the most complex, sequenced motor task the human body performs.
It's a compounding of three separate neurological failures. First, you have the profound oromotor hypertonia, the physical weakness of the diaphragm, vocal cords, jaw, tongue, and lips.
And second, you have the delayed myelination in the specific language output centers of the cerebral cortex. The signal literally degrades before it reaches the brainstem. And the third factor,
Severe verbal apraxia. This is a higher-level cortical motor planning disorder.
meaning the brain knows exactly what word it wants to say.
But the intricate software program required to perfectly sequence the dozens of micromuscle contractions needed to push the air and shape the vowels is completely corrupted. The connection between the thought and the execution is severed.
So they are entirely reliant on AAC, augmentative and alternative communication.
Absolutely. AAC is their only bridge to the outside world.
But let's connect the dots here. Let's look at what AAC actually requires from the child. If we start with low-tech options, like manual keyword sign.
For a child to learn and use keyword sign, they must possess the visual acuity to clearly see the therapist's hands, the visual processing to interpret the spatial movement, and the motor planning to mirror that sign with their own hypotonic hands.
And if that child has severe uncorrected myopia, or if their eyes are constantly jumping with nystagmus, the therapist's hands are just a blur. They cannot learn the visual language because the sensory gate is closed.
Precisely. Let's step up to a more complex system. PODD books. Pragmatic organization, dynamic display.
Right, these are those comprehensive binders filled with hundreds of tiny specific symbols and pictures. The child must scan the pages and point to symbols to build a sentence like, I want to go outside.
Now imagine asking a child with uncorrected strabismus and profound eye muscle fatigue to scan a complex grid of 50 tiny symbols.
The cognitive effort required just to focus their eyes leaves zero energy for the actual linguistic task of building the sentence.
It's an impossible ask. And then we arrive at the apex of AAC technology. High-tech eye gaze devices.
These machines are miraculous. I've seen them used by adults with ALS. A highly sensitive infrared camera mounts below a tablet screen, locks onto the micro-movements of the user's pupils, and the child literally uses their eyes as a computer mouse.
They stare at a word on the screen for a fraction of a second to click it, and the computer's synthetic voice speaks the sentence for them. It has revolutionized the lives of people with locked-in syndromes.
But consider the absolute prerequisite for an eye gaze camera to function. It requires a stable, relatively predictable pupil to track and calibrate against.
Oh, I see where this is going.
Right. If a child has uncorrected strabismus, the camera is trying to track two eyes, looking in entirely different directions.
And if they have nystagmus, the pupil is jumping out of the camera's frame 10 times a second.
Exactly. The high-tech software cannot calibrate. The machine fails to recognize their intent, and the child remains locked in.
And we must bring the auditory environment into this AAC equation as well, because these high-tech devices provide constant auditory feedback. The machine speaks. The classroom is full of typical ambient noise.
And if that child's auditory pathways are uninsulated, if the mechanical hum of the device or the sound of a chair scraping across the classroom floor triggers their hyperacusis,
Their autonomic nervous system is instantly hijacked. They're thrown into a massive sympathetic fight-or-flight startle response.
their heart rate spikes, their adrenaline surges, their muscles lock up.
In that state of physiological terror, the prefrontal cortex, the part of the brain required to logically build a sentence on a screen, goes completely offline.
They cannot possibly focus on communication when their brainstem is screaming that they're under acoustic attack.
Yeah.
This right here is the absolute core message of this deep dive.
It's the whole picture coming together.
To every parent listening,
Yeah.
when you spend 3 hours in a waiting room to see a pediatric ophthalmologist, or when you are aggressively fighting your local school board to install acoustic dampening panels in your child's special education classroom, you are not just managing secondary sensory symptoms.
You are quite literally building the physiological bridge that allows your child's high, trapped intelligence to cross over into expressive communication. Treating the eyes and protecting the ears is the key to unlocking their mind.
It is the foundational prerequisite for their autonomy. It is a profound realization. But, as you know all too well, while you are waging this daily battle for sensory regulation, AC calibration, and seizure control, you are simultaneously forced to monitor a completely hidden, equally dangerous set of systemic issues.
Because the pure alpha protein is missing from every cell in the body, that broken blueprint affects the actual physical architecture of the child.
Let's move from the nervous system into the rest of the body. I want to look at the skeletal structure, the endocrine system, and the gut.
Because the genetic mutation is ubiquitous, the downstream physiological consequences are seen in almost every major organ system. Let's begin with the skeleton.
Because the profound central hypotonia we discussed earlier actively harms bone development over time. Break down that mechanism for us. Because we generally think of bones as static scaffolding. You grow, the bones get longer. Why does low muscle tone damage the bone itself?
It comes down to a physiological principle called Wolff's Law. Healthy bone tissue is incredibly dynamic. It constantly remodels itself based on the mechanical stress placed upon it.
Okay, so when a typical toddler runs, jumps, and falls, the muscles violently pull against the bone.
Exactly. And the impact forces of gravity tell the osteoblasts, the bone-building cells, to lay down more calcium. The bone grows denser, thicker, and straighter in direct response to that dynamic weight-bearing stress.
But a child with severe PURA syndrome is often non-ambulatory. They aren't walking, jumping, or loading the skeleton with gravity.
Right. Furthermore, their skeletal structure lacks the tight, constant muscular scaffolding that typical resting muscle tone provides. The spine is essentially a stack of blocks held together by rubber bands.
And if the rubber bands, the core muscles, are completely slack, the blocks begin to shift, leading to progressive scoliosis.
Progressive severe scoliosis is documented in roughly 48% of the patient population. The spine literally curves, twists, and rotates. And this isn't just a postural issue.
If the curvature becomes severe enough, the rib cage physically twists inward, compressing the thoracic cavity and slowly crushing the lungs.
Which is catastrophic for a child who already has central respiratory weakness. It creates a lethal compounding effect.
This is why many of these adolescents ultimately require massive, incredibly invasive spinal fusion surgeries. The orthopedic surgeons must insert long titanium rods to physically force the spine straight, just so the child can breathe and sit upright in their customized wheelchair.
And the hips are equally vulnerable to this lack of muscular support. The hip joint is a ball and socket. In early childhood development, the physical act of standing and bearing weight actively forces the ball of the femur deep into the pelvis, grinding out a deep, secure socket.
Without that weight-bearing action, the socket remains shallow and flat.
Yes. This leads to severe hip dysplasia, where the femur easily subluxates or fully dislocates out of the joint, causing agonizing pain.
The registry also specifically notes that the actual density of the bone material is compromised. Osteopenia.
The bones are critically thin and brittle. This is a multifactorial failure. It's partially the lack of Wolff's Law weight-bearing, but it's heavily compounded by chronic vitamin D deficiency, which is inexplicably prevalent in this specific population.
And doesn't the seizure medication play a role too?
It does. The massive doses of heavy anti-epileptic medications these children require actively interfere with calcium metabolism, leaching minerals directly out of the bones.
So the risk of a pathological fracture, meaning bone snapping, not from a massive fall, but from a routine movement like a diaper change or transferring the child to a wheelchair, is a constant, terrifying reality.
It requires extreme care handling the patient at all times.
Okay, let's shift to the endocrine system, the hormonal control center. The clinical literature frequently points to dysfunction in the anterior pituitary gland. Walk us through how a lack of PURA alpha disrupts the hormones.
The endocrine system operates on an incredibly complex feedback loop, heavily regulated by the hypothalamus and the anterior pituitary gland at the base of the brain. The hypothalamus is the master clock.
It secretes releasing hormones that tell the pituitary what to do.
Exactly. But remember, the PURA alpha protein is vital for embryonic neural development. If the cellular architecture of the hypothalamus is disorganized, the entire hormonal cascade is thrown out of rhythm.
Clinically, what does that look like in the child?
We see profound growth deviations. Some children require synthetic growth hormone therapy to achieve basic physical milestones. We see highly abnormal timing of puberty.
Like precocious puberty.
Yes. The master clock triggers prematurely. You may see a 7 or 8-year-old child who is nonverbal and cognitively functioning at an infantile level suddenly thrown into the biological chaos of full physical puberty.
Or alternatively, the puberty can be severely delayed, requiring an endocrinologist to step in and chemically suppress or replace those hormones. The sources also detail a terrifying issue with thermoregulation. Hypothermia.
The autonomic nervous system's ability to maintain a core body temperature is frequently broken. The preoptic area of the hypothalamus, which acts as the body's thermostat, fails to properly sense the blood temperature or initiate the shivering reflex.
So these children can become dangerously hypothermic very rapidly, even in seemingly mild air-conditioned environments. Their extremities become ice cold because their vascular system isn't constricting properly to save core heat.
It's incredibly dangerous.
Finally, we have to look at the gastrointestinal tract, because the gut is basically one giant muscular tube.
And it is heavily controlled by the enteric nervous system. When you have global central hypotonia, it doesn't just affect your biceps, it affects the smooth muscle of the intestines.
The peristalsis, the rhythmic squeezing action that automatically moves waste, is incredibly weak and sluggish. Combine that weak internal squeezing with the fact that the child is immobile in a wheelchair, and the bowel simply stops moving.
Chronic, severe, intractable constipation is a near universal complaint in PURA syndrome. It requires incredibly aggressive daily management.
We are talking about chronic use of osmotic laxatives, highly specific high-fiber formulas through their G-tube, and sometimes daily enemas just to prevent life-threatening bowel impactions. I have to pause here, because we've just outlined a terrifying list of silent, internal systemic failures. It's a lot to take in. If a child with PURA syndrome is entirely nonverbal, if they cannot point to a pain scale chart, if they can't say, "my hip hurts" or "my stomach is cramping," how on earth does a parent or even a doctor know that the child is experiencing a microfracture in their femur or agonizing pain from an impacted bowel?
That is the most exhausting, emotionally taxing part of the caregiver's reality. You are forced to become a master behavioral detective, because when expressive words are entirely unavailable, behavior becomes the communication.
So an escalation in behavior is actually a medical symptom.
Absolutely. If a child who is typically affectionate and relatively calm suddenly develops intense, unexplainable anxiety, if they begin showing extreme sensory-seeking behaviors, or worse, if they suddenly start self-injuring, violently biting their own hands, or repeatedly hitting their head against their wheelchair headrest, you must immediately assume a medical origin.
It's a desperate expression of trapped physical pain.
Exactly. Furthermore, if you see a sudden, inexplicable spike in their seizure frequency, or if they suddenly lose the ability to perform a motor skill they previously mastered, that is very often not the PURA syndrome itself progressing.
It is their fragile neurological system reacting to a hidden physiological stressor. It's often the only sign you get of a silent urinary tract infection, severe constipation, or an undiscovered bone fracture.
The vigilance required to monitor that is absolute 247 labor.
And because of these systemic vulnerabilities, the need for G-tube placements, the strabismus eye muscle adjustments, the massive spinal fusion surgeries, the dental work under sedation, these children are frequently forced into the operating room. Which brings us to a highly specific, extremely dangerous medical hurdle that every single parent needs to be intimately aware of. I want to talk about the orphan anesthesia guidelines.
This cannot be stressed enough. Orphan Anesthesia publishes the gold standard perioperative guidelines for rare diseases. And their protocols for patients with PURA syndrome undergoing general anesthesia are stark, specific, and full of red flag warnings.
Because their bodies process pharmacological agents entirely differently. Let's break down the specific dangers. What happens when you sedate a brain that lacks pure alpha?
The most critical life-threatening danger is their extreme, prolonged sensitivity to sedative medications and respiratory depressants. Remember, these children already have a structurally compromised brainstem respiratory center and profound upper airway hypotonia.
If an anesthesiologist administers a standard weight-based dose of an opioid painkiller like fentanyl or a benzodiazepine sedative, the child's respiratory drive can completely shut down.
And it doesn't just shut down during the surgery, it stays shut down. They have a drastically prolonged emergence and recovery time. They don't wake up and start breathing on their own on a normal timeline.
Because the pharmacokinetics are completely skewed. The guidelines explicitly recommend drastically reducing the doses of opioids and benzodiazepines, often by roughly 50%. Let me push back on this purely from an advocacy standpoint.
Sure.
If there are published guidelines, why can't a parent just trust that the local hospital's anesthesiologist will look this up and know what to do? Why is the burden on the parent?
Because the mathematical reality of rare diseases is unforgiving. With fewer than 1,000 confirmed cases globally, it is almost a statistical certainty that when you arrive at your regional pediatric hospital for a routine G-tube change, the surgeon and the attending anesthesiologist will have never heard the word PURA in their entire medical careers.
They simply won't know to look up the guidelines because they don't know what they don't know. And that lack of knowledge dictates the postoperative care plan. Because for a typical child, a minor eye muscle adjustment is an outpatient day surgery. You go home that afternoon. But for PURA syndrome,
Day surgery is unequivocally off the table. The orphan anesthesia guidelines mandate a minimum 24-hour inpatient admission following any exposure to general anesthesia, regardless of how minor the actual surgical procedure was.
the child must be placed in an ICU or a high-dependency step-down unit on continuous pulse oximetry and capnography monitoring for a full day and night.
The risk of delayed central apnea or their airway collapsing in their sleep as the residual anesthetics slowly clear their system is astronomically high.
And we also have to factor in the thermoregulation failure we talked about earlier.
Mm.
Operating rooms are kept notoriously freezing cold to prevent bacterial growth.
Which triggers a physiological crisis for a child with PURA. Active thermoregulation is mandatory from the moment they enter the OR. The team must use forced air warming blankets. They must actively warm all intravenous fluids and monitor core temperature continuously.
If the child becomes hypothermic during surgery, it alters the binding of the anesthetic drugs, prolongs the wake-up phase even further, and severely compromises blood clotting. There is also the physical airway management during extubation.
Because of the profound dysphagia and weak swallowing reflexes, there is a massive risk of aspiration during the induction of anesthesia and during the critical wake-up phase. The medical team cannot simply pull the breathing tube and assume the child will clear their own secretions.
Prophylactic nasopharyngeal airways, soft tubes left in the nose to keep the upper airway open, are often required deep into the recovery phase. And finally, the epilepsy management during the fasting period.
Crucial. All anti-epileptic medications must be rigorously continued. If the child is NPO, meaning nothing by mouth before the surgery, the hospital pharmacy must prepare exact intravenous substitutes for their specific seizure medications.
The physiological stress of surgery, combined with missed oral meds, is a massive, highly documented trigger for sending the child into status epilepticus. So what does this all mean? To summarize this gauntlet for the parents listening, you must be the ultimate, uncompromising, immovable advocate.
You really do.
You cannot be polite and assume the medical team knows best. You have to literally print out the orphan anesthesia guidelines. You physically hand them to the anesthesiologist in pre-op and state, "My child requires a 50% reduction in opioids, active forced air warming, and an automatic 24-hour ICU bed, and I will not sign the consent form until that is confirmed."
You are the guardian of this specific life-saving knowledge. It is an immense, unfair burden placed on the shoulders of the caregivers, but it is absolute life-saving advocacy.
It is. Having navigated this absolute gauntlet, the terror of the NICU apneas, the diagnostic maze of the epilepsy and hyperacusis, the orthopedic surgeries, the AAC trials, let's take a breath and look forward. Because amidst all of this clinical severity, there is a beautiful, enduring reality. These children survive.
And they grow.
I want to talk about the long-term natural history of PURA syndrome, the transition to adulthood, and the incredible power of the patient community.
The most important fundamental reassurance we can offer to a parent who has just received this genetic diagnosis today is this. PURA syndrome is a neurodevelopmental condition. It is not a neurodegenerative condition.
Meaning the brain is built differently from the start, but it doesn't actively waste away. They don't slowly lose the skills they thought so incredibly hard to gain.
Exactly. This is completely unlike devastating degenerative genetic diseases where a child develops perfectly normally for 2 years and then slowly, agonizingly loses their ability to walk, talk, and swallow. Children with PURA syndrome are on an upward, albeit incredibly slow and uniquely angled trajectory.
They continue to make hard-won, continuous forward progress throughout their entire lives. Yes, the developmental gap between them and their typical peers widens significantly as they age, but they do not regress, provided their epilepsy is aggressively and successfully managed.
So, assuming the family can protect the respiratory system from severe aspiration pneumonias and keep the electrical storms of the epilepsy under control, survival well into adulthood is the clinically expected outcome.
The PURA Syndrome Foundation's Global Registry has actively identified and documented multiple patients living in their 30s, 40s, and 50s. But the intensity of the required care does not diminish.
No, it does not. These individuals will require 24/7 round-the-clock intensive care for all activities of daily living for the entirety of their lives. They will always require full assistance with feeding, personal hygiene, transferring from bed to wheelchair, and complex medical coordination.
Which makes the transition planning from pediatric to adult care an absolute monumental undertaking for the families.
It is a massive systemic hurdle. It involves navigating complex legal frameworks for adult guardianship. It involves the terrifying transition away from specialized pediatric neurologists who are used to complex congenital syndromes to adult physicians who primarily deal with acquired issues like strokes or Parkinson's and are often completely ill-equipped to manage a nonverbal adult with a rare pediatric genetic disorder.
And we have to talk about the emotional and behavioral landscape of these older patients, because they're not just fascinating medical files. They are living, breathing teenagers and adults with complex emotions, deep frustrations, and physical desires.
And generally, their baseline disposition is a joy. Families universally describe their adult children with PURA as incredibly loving, highly attuned socially, and deeply friendly.
But navigating adolescence and adulthood when you possess high receptive intelligence, yet suffer from profound physical disability and a total lack of expressive speech, creates intense psychological pressure, especially when the endocrine system kicks in and the hormones of puberty flood the system, or when their meticulously managed daily routine suddenly changes.
Precisely. Teenagers and adults with PURA can experience bouts of intense, overwhelming anxiety. This is often triggered by changes in their caregivers or, circling all the way back to our core theme, by sensory overload.
A loud, chaotic environment, a sudden change in fluorescent lighting, an unexpected tactile sensation. These sensory assaults can trigger severe behavioral outbursts because they can't simply articulate, "The hum of these fluorescent lights is giving me a migraine, please take me home."
Exactly. So that unexpressed anxiety and sensory pain manifests physically. It presents as extreme, sensory-seeking, intense, prolonged rocking, hand-flapping, vocal stimming. Or in the most heartbreaking clinical scenarios, it turns inward as self-injury.
They may violently bite their own arms or hit their heads against the wall out of sheer frustration at being fundamentally misunderstood by the world, or as a desperate mechanism to self-regulate an autonomic nervous system that is misfiring.
Which means providing rigorous, consistent, highly visual daily schedules, utilizing their AAC devices faithfully, and maintaining strict sensory regulation strategies is not just educational, it is vital psychiatric and mental health care for these adults. It is the foundation of their quality of life.
And crucially, families do not have to figure this landscape out in isolation. As we close out this deep dive, we have to highlight the most powerful tool currently existing in the rare disease space: the patient community. The sources we read draw incredibly heavily from the PURA Syndrome Foundation.
And the role of that foundation cannot be overstated in the medical literature. Because the disease is so ultra-rare, your local pediatrician is flying completely blind. The foundation has stepped up to become the central global node of clinical knowledge.
But it is vital to understand that they are not just a Facebook support group sharing tips on which feeding pump works best, or how to navigate insurance appeals, though that support is incredibly vital. But they are operating on a much higher scientific plane. They are a highly sophisticated, aggressively mobilized engine driving actual functional research. They manage the global patient registry, right?
Yes, in direct collaboration with major genetic research universities, they are meticulously tracking the longitudinal data of every known patient. They are tracking the seizure types, the scoliosis progression, the AAC usage. They are doing the hard, grinding work of actually defining the natural history of the disease for the medical establishment.
But even more critically for the future, they fund and manage the global biobank. Explain what the biobank is, practically speaking, because it sounds like science fiction.
It is the physical infrastructure for a cure. The biobank is actively collecting actual biological samples, like skin biopsies or blood draws from PURA patients all over the world. Researchers then take those skin cells and use advanced techniques to create what are called immortalized cell lines.
Meaning the cells continue to replicate indefinitely in a lab environment.
Exactly. And those cell lines are distributed to genetic scientists globally. This allows researchers in Germany or Australia or the US to study the exact behavior of the defective pure alpha protein in a petri dish. And crucially, it gives pharmaceutical companies a physical platform of human PURA cells on which to test thousands of potential drug compounds.
The parents are literally funding, organizing, and physically supplying the science to save their own children. It is absolutely awe-inspiring advocacy.
It is the ultimate testament to parental love driving medical innovation.
Which brings us to the end of our time today. I want to speak directly to you again, the parent, the carer, the sibling listening to this. We know we just walked you through an avalanche of daunting, heavy clinical biology. From the mechanics of central hypotonia and brainstem apneas to the complexities of refractory epilepsy, progressive scoliosis, and the terrifying realities of anesthesia risks.
We know the sheer volume of medical management you coordinate on a daily basis is the logistical equivalent of running a small hospital out of your own living room. It is a profound, exhausting, heroic labor of love and vigilance.
But if there is one actionable, critical takeaway we want to leave you with from this deep dive, one thing to hold on to amidst the chaos of specialist appointments, it circles back directly to our central mission, the vision and hearing connection. Amidst all the massive orthopedic surgeries, the G-tube button changes, and the daily calculus of seizure medications, please fiercely prioritize the pediatric ophthalmologist and the audiologist.
Because treating a squint with surgery, prescribing highly specialized refractive glasses, or rigorously managing the acoustic environment to prevent those hyperacusis startle responses, these are not secondary cosmetic or behavioral concerns. They are fundamental neurological lifelines.
By physically correcting their vision and aggressively protecting their auditory processing, you are clearing the sensory static. You are giving their brilliant, highly receptive, trapped minds the physical tools they desperately need to engage with augmentative and alternative communication. You are directly empowering your child to finally bridge the gap, to show the world what they understand. You are building the road that gives them their voice.
And I want to leave you with one final, deeply provocative, forward-looking thought. Something that isn't explicitly detailed in standard clinical care guidelines yet, but is heavily whispered in the advanced genetic research corridors. Let's go all the way back to the blueprint. We know the exact structure of the PUR-alpha protein. We know it binds specifically to RNA.
Right. And we know that the root cause of this entire multisystemic syndrome is a single localized, identifiable spelling error in a single exon gene. It's not a mystery disease. We know exactly where the typo is.
Currently, the FDA and global regulators are creating accelerated pathways for what they call plausible mechanism, targeted therapies for ultra-rare diseases. Researchers are actively working on viral vectors using modified harmless viruses that could theoretically act as delivery trucks to insert a perfectly healthy manufactured copy of the PURA gene directly into the central nervous system.
Wow. Gene replacement therapy.
The speculative, tantalizing scientific question is this. If a future viral vector gene therapy could successfully restore the production of PUR-alpha directly in the brain of a child, what would it actually fix? Could it do more than just improve baseline muscle tone? Could it actually rewind the myelination deficits?
Wait, you're saying it might insulate the bare wires?
Imagine a future treatment that doesn't just help a child manage their extreme hyperacusis by forcing them to wear heavy noise-canceling headphones. Imagine a treatment that structurally repairs the sensory filters in the white matter of the brain. A treatment that allows the supranuclear control centers to finally coordinate the eye muscles without surgery.
Meaning the brain could finally mix the auditory levels and focus the visual lens entirely on its own.
Exactly. It holds the ultimate possibility of permanently, structurally unlocking that trapped, highly receptive intelligence we know resides inside every single child with PURA syndrome. It is no longer science fiction. It is a concrete, viable scientific roadmap currently being painstakingly executed by the researchers supported by your community.
It is the ultimate, incredibly real hope. At the start of this conversation, we talked about that broken X-ray machine, how diagnosing and living with a complex whole-body neurodevelopmental disorder like PURA syndrome feels like navigating through dark, terrifying, diagnostic, muddy waters. The cause is infinitesimally microscopic, but the storm it creates across the body and the senses is completely overwhelming.
But the waters are clearing. With every single patient added to the global registry, with every new immortalized cell line in the biobank, the picture comes into sharper, more actionable focus.
We are finally starting to see the true blueprint, and more importantly, we are learning how to read it. Thank you for joining us on this deep dive into the vision and hearing connection of PURA syndrome. Please continue to explore the incredible resources, the complex care guidelines, and the cutting-edge research updates provided by the PURA Syndrome Foundation. You are doing an incredible job, and you are not alone in this fight. We will see you next time.